Un'agenda è fatta di anni, mesi, giorni ed è giorno dopo giorno che stiamo ricominciando, in modo sostenibile, inclusivo, intelligente. Ehi gente, vi chiedevate quando saremmo ripartiti? Adesso riprendiamo a camminare, a correre, volare. Abbiamo tanta energia, energia pulita e rinnovabile. Rinnoviamo il modo di interagire. Io e te, lui e lei, abbiamo voglia di starci a sentire. Non sarà facile, insieme ce la facciamo. Partecipa al Festival dello Sviluppo Sostenibile 2021. Mettilo in agenda, stiamo agendo. Contribuisci al raggiungimento degli obiettivi dell'Agenda ONU 2030.
Good morning. My name is Fabio Torriglia. I'm the country manager of Beatrice. I represent Beatrice, a new model of a global company working in the health sector. Beatrice was established in November 2020 thanks to the combination of Myland and Upjohn. We provide medications for transmissible diseases. We support and develop innovative therapeutical solutions. We can count on our collective experience in order to improve overall health. Moreover, we also believe that companies can truly commit themselves to making the difference. We collaborate with qualified partners all over the world and with institutions in order to contribute to the search for practical solutions to meet the most urgent challenges in the health, environmental and social sectors. We are committed for long-lasting change. These are the reasons why Beatrice signed the UN Global Compact, and we actively support through actions aimed at sustainable development this objective. Our values and goals make us partners of Asvis in the framework of the Sustainable Development Festival. We support the day devoted to the objective number 3, health and well-being, which are priorities for our company. We believe in healthcare not as it is, but as it should be, accessible for all. Our mission is to allow people all over the world to enjoy a healthy life. We believe that health is essential anywhere and at all times, and we would like this vision to become practice. We work with Beatrice to develop healthcare in the future, and this is one of the topics that we're going to discuss today. So let's turn our commitment for sustainability into 5 practical working areas. First, patients' healthcare. We want to provide access to high-quality pharmaceutical products. We cover 94% of low, medium, low income families. We also deal with health and well-being of our collaborators. We have more than 40,000 members of staff. And then environmental health. We have a measurable environmental program. Since 2015, we have been increasing renewable energy by 485%, and we have implemented plans to minimize our environmental impact. And we're doing much more. This is done on a daily basis thanks to our sustainable behaviors. And then the health of the community. We can count on our assets in order to support health, prevention, education, and welfare in a widespread way. And finally, the 5th area, global healthcare. Thanks to our partnerships with associations, we work with institutions at all levels. We guarantee wider access to pharmaceutical products and services in order to improve healthcare and prevention. In 2020-2021, during the COVID-19 pandemic, we worked hard to share our scientific knowledge, support public health, support our staff, and guarantee continuity of production in all our manufacturing sites. We're working on a daily basis to disseminate the culture of sustainability in the 5 areas I've just mentioned. We involve our members of staff in training initiatives, ongoing training, in order to make sure that behaviors that are in line with the Sustainable Development Goals are implemented on a daily basis. We will keep on working in order to exercise an impact through our behaviors as individuals and as a company that is in the forefront of healthcare. Within Beatrice, we're going to support our goals, and we will share them in our sustainability reports, which are published on an annual basis. Thank you very much. We're working together, and we will keep on working together. I wish you all a fruitful meeting. Good evening. Good evening to those of you who are connected from far away, and good evening to those of you who are sitting in the audience. We heard it at the very beginning. We heard about the 17 goals for sustainable development. It goes without saying that the pandemic has challenged these goals. Suffice it to say that defeating poverty, gender equality, economic growth, and labor dignity, health and well-being have been seriously challenged. The very concepts of health and well-being are now at the core, at the center of these objectives. It is undeniable that the pandemic can be an opportunity. Why? Inequalities existed even before the pandemic. However, the pandemic has made them even more evident, so we cannot just look away, and these problems have to be tackled once and for all. Before and after COVID-19, how can we redesign the healthcare system in the framework of equity? And I will now give the floor to Professor Ricciardi, Professor of Hygiene at Università Sacro Cuore and Chancellor of the Minister for Health. Good evening. Here we are. Just an aside comment and a question everybody would like to ask you. What about the present pandemic situation? Well, it depends on the place. In Italy, we're doing well. Italy is among the best European countries. We are among the best after Denmark and Portugal in terms of vaccination campaign, reduction in the number of cases, and pressure on the healthcare system. This is not the case for other countries. It is the worst moment for the United States, Russia, Brazil. In these countries, they still have thousands of victims. We cannot lower the guard. We cannot rest on our laurels. This is a very important moment for the country. Next Friday, Green Pass, the vaccination certification will become compulsory all over the country, and this is the only way to go back to a normal situation. Back to today's topic, the deficiencies of our healthcare system have clearly emerged. What can we do? Italy, in the framework of the National Recovery Plan, has quite a lot to accomplish. Italy is giving a significant contribution. Of course, we would like the overall situation to improve at a global level. Maybe not everybody is aware of that, but the WHO and the United Nations are fighting a diplomatic war. As you said, we don't want inequalities to explode. We don't want inequalities to become too severe. So we need an international treaty, the so-called Global Pandemic Treaty, which does not exist yet. Right now, individual countries are going on their own, and this is not useful in case of a pandemic. Yesterday, the UK Parliament criticized the government for the damage they caused. They talked about the failure of the UK healthcare system, They talked about an unprecedented failure with thousands of victims, which could have been avoided. And not only was the UK detrimental to themselves, they were detrimental to us as well. They allowed the Delta variant to come into Europe from India. Because of a flight from London, the Delta variant spread everywhere. Italy is one of the friends of the Global Pandemic Treaty. It's a group of 26 countries, and we're working hard to have this treaty approved. This is the only way out from the pandemic. The rest of the world will be vaccinated by 2024. So 2022, 2023 will be a long time, and many more variants might emerge. So this is a fight for the survival of the planet. Italy is a unique country in terms of inequalities. For 20 years, we have had a national healthcare system in place. However, there are remarkable differences between northern and southern Italy. If you live in southern Italy, you have less access to healthcare services, less access to screening programs, and less access to medications. If no prevention is carried out, and if you think about breast cancer, well, the incidence rate is lower in southern Italy for genetic reasons, but the mortality rate is higher. So the National Recovery Plan does contain provisions, but this is not enough. The National Recovery Plan is going to invest on assets, on the building of community hospitals, community houses. There will be investments for technologies, for the replacement of the hospital equipment, and funds will also be invested on digital transformation. Of course, they are very important goals because we're still lagging behind. But people who work in the community hospitals, in the community houses, the people who have the skills to handle the digital technologies, where are they and how are we going to train them? We still don't have these people. There are not enough people who have been trained on these new activities, so we need to start acting now. I don't know if I'm going to unveil something that is not known yet, however. It is important for you to know that in the additional note to the financial plan, what they allocated for 2023 for staff is much less than the period before the pandemic. So when we say we learned a lesson from the pandemic, this is not true. We still have not learned. We have not learned in terms of decision making. So we need to make choices here. We need to invest funds on the healthcare system. Otherwise, there will be buildings, but no possibility to have these hospitals and buildings work. I realize these are technicalities because many people don't know about these issues, but it is important for you to understand that if we do not get to this global pandemic treaty whereby countries will be forced to do certain things, we want to avoid situations like the situation in Brazil. Think about the Amazon forest and people living in the suburbs in Brazil. Of course, we need to strengthen the WHO, and the WHO needs to perform better and be more transparent. And similarly to the objectives for sustainable development, this is something that should be entrusted to the United Nations. It will be up to the countries to decide. And I'm very proud to say that Italy is in the forefront. We are in the forefront when it comes to the pandemic treaty, and the vaccine is a global asset for us. unless patents are discontinued, at least for a certain period of time, unless intellectual property is removed for a short period of time, unless technological transfer is carried out, if we don't teach countries like India, Indonesia, South Africa to manufacture their own mRNAs vaccines, if we don't help them produce, well, it goes without saying that there will be companies making a lot of money, but the pandemic will continue for many years ahead. The foundations have been laid, but much remains to be done. Back to Italy. You talked about the gap existing between northern and southern Italy, and because of the pandemic, this gap has become even wider. Screening campaigns, for example, cancer screening campaigns, as you said, prevention is paramount. Not only have screening campaigns been postponed, but we don't even know when they will be resumed. Again, it is a problem to resume the screening campaigns. Talking about gaps, southern Italy and rural areas are lacking the human capital. There are places where you have no specialists. There are places where services cannot be provided because there are very few specialists available. And this is due to the fact that they have not been trained for a long period of time. Funds have now been allocated, but new specialists will be trained in 4 or 5 years from now. So we need strategic plans because starting from GPs who will retire, so there will be areas in southern Italy that will be lacking GPs, but also for certain specialty areas we're lacking specialists. This is why we need a homogeneous plan. This is not simple in Italy. Because of the Italian constitution, it is up to the regional governments to create and develop their own healthcare systems. We cannot change the national constitution, of course. In my opinion, the constitution should be amended and the central government should be allowed to take action. I've said it again and again. When I worked for the Higher Institute for Health, even when deficiencies or gaps were evident, we could not take any action simply because actions have to be taken by the regional governments. Now, if the regional government is efficient, that's not a problem. But as the pandemic showed, even in the biggest and richest region in Italy, there was a very high number of victims. Back in February 2020, I tried to explain it to our foreign colleagues. I had to explain to them that we were having problems in Bergamo, Brescia, Piacenza, Lodi, that is the wealthiest part of the country. Now, if we had such a high mortality rate in the richest region, let alone the poorest regions in southern Italy, I think the citizens are not always aware of these priorities. The citizens do not fight for the healthcare system. So the disease is usually an individual problem, a family problem. People now take to the streets to in a way, criticize the national healthcare system. It's time for the citizens to wake up. Very good, thank you. Now, talking about the topic that was mentioned by Professor Ricciardi, we were talking about regenerating communities, regenerating the desire for health. What does it mean? We have Dr. Lucio Maciocia here with us, representing the Italian Society for the Promotion of Health.
Good evening. Please take your mask off. Good evening. can and how can the pandemic to regenerate a desire for health and community? Certainly the pandemic has highlighted the current trend, that is to say, to somehow disrupt local communities that have been suffering from isolation and separation and inside families. With COVID, this has been emphasized. Families have faced COVID alone. Solidarity was initially very good. Later, starting from September, October, this feeling of solitude, of loneliness, isolation, and fear were higher. And this has been, and this has stayed within the family, inside the family. In terms of mental health, belonging to a community and playing an active role is a great protection factor. So regenerating health means that we have the opportunity to turn the spotlights on the community. We need to give space to communities. I work in the ASL of Frosinone. I'm responsible for pathological addictions at the Department of Mental Health there, and we have come to realize that a difficult situation can originate a desire to start again, to pay attention to relationships with others, with other people. So we're trying to focus on these aspects. The following speakers, like Professor Virgilio, will present an instrument that has been there for a long time, promotion of health. This is a methodology, a philosophy, much debated but poorly, hardly practiced by healthcare systems, and we do need to talk about promotion of health. Another aspect will be addressed by Silvia Di Passio. She works with small Sardinian communities. Wonderful places in Sardinia, life expectancy is very high, but they are dying. They are dying out, no more young people, no services, so we have to start from small communities through an active participation. Co-designing activities and projects. We want to engage the population to encourage them to participate. At first sight, you may say, what about health? It has nothing to do with health, not at all. Wherever there is isolation, anxiety and solitude, health tends to worsen. Whenever there is a sense of belonging, there is solidarity, there is active participation, health improves. And even in chronic illnesses, there is a community near you. It makes you feel less alone. And why solidarity has been disrupted with the pandemic? Well, because of isolation. COVID has been cheating on us all, as it were. It was the pandemic to prevent people from touching each other. The prevention measure was distancing, and this is not natural at all. And we expect to see serious consequences among children, no socialization, spending your time at home is very dangerous. And it seems that adolescents and children are suffering from this. This has been a heavy burden for families. We also organize groups with COVID patients, and our feeling is that aside from physical symptoms, it's hard for them to be in contact with others. They no longer trust others. We're citizens and consumers in particular. Now we are more consumers than citizens. We want to go back to being conscious citizens, to have one more option to participate. This is very important for psychic health. So what can you do in practical terms? Professor Giglio will talk about an opportunity that is also envisaged by our recovery plan. Healthcare units, healthcare companies are shifting their focus on solidarity, working with the second and third sector, voluntarist associations, make contacts with social services in towns. And also we want to promote the culture of participation, and this can be done also in healthcare companies through specific tools. We don't know yet what community houses will become in terms of health and creating well-being. However, I think that this too can be an opportunity in small towns, for instance, where they badly need care and assistance, and delivering care is very difficult. IT systems, telemedicine may be the answer. So we put together technology innovation and the need for small towns to receive home-based services, and also home care is very important. Yes, telemedicine actually could make you feel even more isolated. This is one additional service. Home-based care is what is needed. Proximity medicine, as it were. Yes, proximity is also important, and that's why we want to deploy re-socialization processes to increase people's ability to socialize, especially in villages and small towns, because those are the places where people suffered more from isolation. It's a cultural issue, very interesting. Now we are going to hold a roundtable session, a panel. Please stay with us. We need your expertise. Health and community, empowerment and organizational functions, the enhancement of organizational aspects. Panelists are Silvia Di Passio, an online guest, Liliana Ockmin, Laura Berti, and Erio Ziglio, professor at the Health University of Applied Science in Austria, and Glasgow Caledonia University in London. We have also guests from abroad. So, please. I'm pleased to take part in this panel because Silvia Di Passio has a very peculiar job. She is a community manager, so she actively follows projects to redevelop and renovate small urban centers in Sardinia. And this has to do with health, because small town have healthcare needs more than others. So I think that this is an opportunity to change the quality of life of the population by actively involving the population. This is my introduction for Silvia. Thank you. Good afternoon, and thank you for inviting me. This topic may seem unrelated from today's discussion. For the last 2 years with the cooperative, I have been taking care of this new developing sector, facilitating participation processes and the reactivation of resources existing in small towns. This is what a community manager does, and I do this in Sardinia. So I'm very happy to be here because I think that complex issues should be tackled through an interdisciplinary approach. So human well-being, regenerative development is something that I bless. As to the impact of the pandemic in my field, spotlights were on inner areas. Why? We should probably talk about them more often, because Italy, 70% of Italy is accounted for by inner areas. We have thousands of small towns where the majority of the population lives. Inner areas are called borghi, small paesi, small villages, and much attention has been paid to them during the pandemic. In small towns and villages, are people living better than in the cities? They have, green areas, people can take a walk. In spite of lockdowns, architect Boeri has spurred this debate. For those who have been working in inner areas for years, this is very positive. On the other hand, this has shown two romantic connotations. Yes, people live well in those areas, but they also have problems. And relative to the cities, the pandemic has highlighted a number of issues. Transportation is more accessible, there is no pollution, so health may benefit from this viewpoint. Is this real? In inner regions, infrastructure is a problem. Healthcare, education, access to cultural opportunities. Politically speaking, real interest was raised in 2013 through a national strategy for inner regions and areas like, midwives, community nurses, telemedicine, and other options. On a daily basis, every day I see that people do have problems. In many small towns, hospitals have been closed down. And so this is an impact, has a huge impact on the population. Or there are no outpatient clinics, facilities are understaffed. Not to mention telemedicine problems. Why? Because in these areas, internet access is difficult, and so digitization is also uncommon. The pandemic indeed has encouraged the development of telemedicine and smart working. Let me make another example. In small towns, new citizens have been added to the local population. We don't want to force people to live where they are, but we want people to spend some time also in small towns, and smart working allowed many people, particularly young people, to move to villages. Marco, for instance, is 30. He moved to Sardinia, and he says rather than commuting and driving for 90 minutes in the morning, I now go surfing for 90 minutes in Sardinia. Now, is it possible to allow the same option to more people? Small towns are not so good for the elderly, which is paradoxical. We have elderly people who are planning to move to the cities because they fear they get sick, they can't reach a hospital soon. So people are moving to Cagliari, Sassari, and the other big cities. Now, the existing potential in small towns is very high, not only because of COVID. Some claim that the higher GDP and the poorer people's happiness. So, are you really prepared to put well-being at the core of local development policies? When I say well-being, I mean several different factors, like social relations, environmental quality, lifelong learning. This is also very important for the elderly. How do you help people in isolation? How do you allow them to keep growing, also with an eye to the community they belong to? As Mr. Macioccia explained, healthcare is related to the level of activism in a community. A community should be a destination, not a departure point. Communities should be alive. When I say community, I mean a group of people having healthy relations who can make proposals, and this brings me back to another topic, health and empowerment. I am responsible as an individual to do things so that I am fine when I relate with others, and the entire community can benefit from my healthy habits. Professor Ricciardi keeps saying that the recovery plan can hardly use funds for more efficient policies, and this scares me, because whatever we are doing in terms of social reactivation oftentimes has no positive outcome, because infrastructure problems are a giant obstacle. We work with the administrations, with local entities, with the third sector organizations. We do need help in this. Thank you. Thank you very much, Silvia Di Passio. This is amazing. We were talking about social cohesion, more solidarity that has been disrupted. People you may think that this is less true in small towns. Liliana Ockmin, coordinator of the Asvis working group on SDG 5, gender equality. This is one of the goals that was most impacted by the pandemic.
The only certainty we have is that the COVID impact has increased inequalities. We had inequality caused by lack of equal opportunities for women in Italy. And the situation got worse for women on the labor market, and because of course women have to look after their families, and the situation got worse for women even in the field of welfare. I'm very grateful to our friends from Goal 3. Our Goal 5, aims at specific goals and of female mutilation, genital mutilation, initiatives aimed at preventing violence against women, abolish discrimination. And for some time now, we have been working hard because we believe that Goal 5 is a goal that involves all the others. Last week we focused on gender medicine that takes gender difference into consideration, and we discussed the requalification of the local healthcare and welfare systems. Of course, we're not starting from scratch. We know that in Italy, gender medicine has been recognized. A law was passed in 2018. An observation center was recently created in the framework of the National Institute for Health. We're now aware of the importance of training and education of all the affected parties. And we also know how important it is to enhance the welfare community. Again, we're not starting from scratch. I believe that it depends on us. We have to give specific answers to specific needs. Of course, the gender difference must be taken into consideration, but we have to be pragmatic and look for sustainable solutions. The healthcare topic has often been associated with the provision of healthcare providers, carers. This is some kind of do-it-yourself welfare. However, we're confronted with a very important challenge. The healthcare sector, and then care for children, people with disabilities, elderly age. This can be a huge flywheel for the labor market. The population is aging, and women are a majority within the society, and women have specific health issues. And if you think about the elderly people, well, people now live longer, but very often in very poor conditions. And this is another challenge ahead of us. The National Recovery Plan did allocate funds, but the appropriate choices must be made. And then the reduction in the birth rate. We need to understand that in order to increase the birth rate, in order to think about the future of a country, you have to focus on women's employment. And again, services at a local level, they generate jobs, hopefully good jobs for many women. When we talk about making investments, and this is one of our main feathers in the cap, when we said we need to invest on proximity welfare, on social infrastructures, this is what we mean. Welfare systems, healthcare systems that take also the progress of digitalization into account. But again, we believe this is going to create jobs for women. When women work, they start planning a better life for themselves and their families. Gender inequality in Italy can only be tackled if we do not consider it as a women's problem. Any recovery plan should have women and young people at the center. Actions must be taken because very often strategic choices are not turned into actions. So we will not be able to overcome the present problems unless jobs, employment, training and education become a priority, not to mention the human capital that is associated with research and enhancement of women's role. And the national healthcare system, well, if you think about Tina Anselmi, who passed away a few years ago, she was the mother of the Italian national healthcare system, a universal system, as the first speaker said, should be inspired by what Italy is doing. Healthcare access must be guaranteed in line with the national constitution. Again, credit goes to Tina Anselmi for creating the national healthcare system. But again, the present challenges must be tackled. Pope Francis stated it would be a sin not to miss this, it would be a sin to miss this opportunity. We cannot afford it. Unfortunately, I cannot see Erio Ziglio. I don't know if he is connected with us. Here he is. Here he is. Dr. Machocha, the floor is yours. He is an educated person, and also I'm sure he can remember all the processes that led to the 2030 healthcare objectives. He was involved in the WHO Europe team. He contributed to a number of initiatives and to the creation of this system. And he's also committed to the promotion of health as a key concept vis-a-vis the 2030 Sustainable Development Goals. And I also asked him to talk about one of the proposals of the National Recovery Plan. I believe this is a very interesting proposal. Just a second, let me add a comment. I know I have an unpleasant role, but I would like to ask you to be as brief as possible because there is so much to discuss, but of course we need to stick to the schedule. Can you hear me? Yes. I will be very short. I will be sharing 3 thoughts. The first one is a thought, and it's also a story connected with my work experience. 35 years ago, I got invited to the first international conference for the promotion of health that took place in Ottawa in 1986. There were 150 experts attending the conference, and finally we agreed on the concept of health promotion, that is, the process through which individuals and communities can increase their ability to control their own health in order to improve their overall health status. We identified 5 action areas. First, second area, create physical environments that are healthier environments. Third, develop attitudes and abilities, allowing individuals to better understand what they can do for their own health, the so-called health literacy. Fourth, reorganize the healthcare systems, and 5, strengthen the local communities with the aim of maximizing their own resources for healthcare and gender equality. Let's think about our own local health units. Very little progress has been made in this field. The 5 principles I've just talked about have not inspired any innovation in the healthcare policies at a local level, and this is true at a local, regional, and national level. Second thought, and I agree with Lucio here, I've just learned that the text of the National Recovery Plan submitted to the European Union contains the establishment of the so-called House of Communities in order to strengthen the local and proximity services. That's great. I hope the so-called community houses can become an integral part of an innovation process, and hopefully they're going to have a favorable impact on people's life in certain areas. I also hope that the community houses eventually are not just a small decentralized outpatient clinic. As a matter of fact, I would like the community houses to become effective tools that are used at a local level for all citizens. Much more could be said about this topic, but I will move on to my third and final comment. I started by telling you about my professional background, and I would like to end with another story. In 2016, the WHO organized the Shanghai Conference titled Promotion of Health and the Sustainable Development Goals. This is also the topic of your discussion today. Unfortunately, we lost the connection. I was at the conference, and when I left the conference, I realized how important it was to promote health and the healthcare policies in the framework of a sustainable development policy that guarantees equity and health. So my hope, to conclude, I know that you are a bit late with your schedule, so my hope that the promotion of health in the framework of sustainable development is not just a conceptual positioning. It should lead to practical actions. It should lead to programs that lay the foundations for programs aimed at the promotion of health. This is why I've accepted your invitation, and I believe the regenerative development is truly needed. And we also need to generate health, equity, sustainable development, taking advantage of new processes, and also taking advantage of our institutions, which do not perform very well at the present right now. Thank you very much for being brief, and we very much appreciated your comments. Professor Machocha, any final comments? And then we will move on to the second session. The contents that have been shared during this meeting are excellent ones. It may sound as a paradox that a representative of the healthcare sector talks about the prerequisites for health. I firmly believe in it, especially because we deal with mental health. Mental health is not measurable in terms of mortality rate, but certainly it leads to social malaise that is much more widespread than one would think. And this is the case for all our societies. And also when it comes to chronic diseases are often associated with mental health. This is why, in my opinion, it is very important to focus on these processes and also pay attention to people. Thank you. and we will be talking about mental health later. Thank you very much for participating. And now we can move on to the next session, session number 2, that is vulnerability conditions. And we would like to start by talking about COVID-19 and earth inequalities. I think we should be able to see Professor Michael Marmot. He is connected with us.
Do we have a bad connection? It's not working.
Can you see my presentation? Can you hear me?
Professor Marmot.
And can you see my presentation?
We cannot see your presentation now. We are seeing you.
I'm
we see you.
Well, I am sharing my screen. And my presentation is there. I'll stop sharing and try again. Can you see my presentation now?
Yes, we can. Okay.
So, may I start?
Yes, please.
Well, as I think has already been discussed this afternoon, COVID exposed the underlying inequalities in society and amplified them. And I've been talking about Build Back Fairer in the light of the COVID pandemic. And I've had to deal with a lot of challenges, and I've called this dealing with apparent oppositions. So the way I want to present it this afternoon is to deal with these questions. Should we be taking a social approach or a medical approach to the pandemic and to inequalities in health more generally? And my answer to both of these, most of the dualities that I'm going to present to you, the answer is yes. We need to take a social approach and a medical approach. So my book, The Health Gap, in Italian, La salute disuguale, the opening line was, why treat people and send them back to the conditions that made them sick? We need to deal with the conditions that make people sick, but we also need to work with the healthcare system. So, for example, in Britain, the nurses produce Nurses for Health Equity. What can they do within the healthcare system to tackle the social determinants of health? We need a social and a medical approach. And when it comes to COVID, do we want disease control or social determinants? Here's the mortality from COVID-19 in England. Men, women look similar by level of deprivation. So the most deprived here, the least deprived there. And the dark green here is all-cause mortality. And you can see the social gradient, the greater the deprivation, the higher the mortality. And the pale green is COVID-19. Goodness. The social gradient looks very similar to the social gradient in all-cause mortality. In other words, the causes of inequalities in COVID-19 are similar to the causes of inequalities in health more generally. I talked to a lot of different health and disease groups, and I was talking at an international meeting of dentists. And I showed them this graph, least deprived, most deprived. You probably can't read that. It's dental caries, decayed, missing, and filled. And it looks identical to the COVID-19 graph. And then I was talking to a group connected with the prevention of heart disease in primary care. So I showed them this graph. This is obesity prevalence in school-age children. It's an identical gradient. What's going on? We think COVID is caused by a virus. We think dental caries are caused by diet and poor oral hygiene, low fluoride levels. We think that childhood obesity is caused by diet, but not a virus. And yet they have identical social gradients, which means that we need to deal with the determinants of health and health inequities, as well as controlling the virus. Targeted or universal? Certainly in Britain, our tradition has been targeted policies. You target the worst off. The problem with targeted policies is you miss the gradient. And in my 2010 Marmot review in England, Fair Society, Healthy Lives, we coined the phrase proportionate universalism. So here's the social gradient in health, social distribution. Let's say less deprivation, more deprivation. And the less the deprivation, the better the outcome. What we want to do is level up across the whole gradient. So we said proportionate universalism means universalist policies with effort proportionate to need. In Britain, after 2010, we had various health problems. What did we get in terms of proportionate universalism? This was the funding of local government by level of deprivation. So in the 20% of least deprived areas, the funding, the spending in local authorities per person went down by 16%. And then the greater the deprivation, the greater the reduction. In the most deprived 20%, the spending went down by 32%. This is effort inversely proportionate to need. The greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Central action or local action? Well, ideally we need both. We want central government to act, but we need action at a local level. Look what I mean. This is child poverty in England. Poverty is defined as living in a household at less than 60% median income. Before housing costs in 2010, 18% of children were living in poverty. After housing costs, that was 27%. Over the decade, the 27% went up to 30%. How did they achieve that? That's quite something. These are changes to the to household incomes due to changes to the tax and benefit system. The red is working age families with children. This is in England. Working age families with children by income decile of the household. In the poorest 10% of households, for working age families with children, income went down by 20% as a result of reforms to the tax and benefit system. In the next poorest decile, incomes went down by 12%, in the next by 8%. The poorer the household, the greater the reduction in income due to reforms of the tax and benefit system. There was some reduction in the high-income households, but nowhere near as great as in the low-income households. So do we need central action? Of course we need central action. The Minister of Finance could change this tomorrow. In fact, he did. Last week, our universal credit system, our welfare system for poorer people, had been raised up by £20 a week during the pandemic, and he took away that £20 between Wednesday and Thursday. So 7 days ago, 300,000 more children were thrown into poverty. Wow, if he can do that from one day to the next, he could reduce child poverty. So yes, we do need central action, but we need local action too. We've been working in different regions of England. In Cheshire and Merseyside, that includes Liverpool. This is COVID-19 mortality by level of deprivation, and it is a remarkable gradient. It's like the England figures, that's the England and Wales average, and the bottom 6 deciles have higher mortality than from COVID-19 than the England and Wales average. And on the 30th of June this year, we published Build Back Fairer in Greater Manchester, Health Equity and Dignified Lives. On the 30th of June, the front page of The Guardian had 2 stories, England 2, Germany 0, and jaw-dropping fall in life expectancy in poor areas, quoting me. You could say both of these stories were jaw-dropping. What I described as a jaw-dropping fall in the northwest region of England, where Greater Manchester is located, life expectancy in 2020 fell by 1.6 years in men and 1.2 years in women. It fell stunningly in England as a whole by 1.3 years in men, 0.9 years in women, but by more in the northwest. So yes, we need central action, but we also are working with Greater Manchester to say, what can they do? And we have a Build Back Fairer framework for Greater Manchester, early years, children and young people, housing, transport and the environment, communities and places, public health, work and employment, income, poverty and debt. It looks very much like my 2010 Marmot review. And then these spokes, Build Back Fairer for future generations, Build Back Fairer resources, Build Back Fairer standards, Build Back Fairer institutions, monitoring and accountability, and greater local power and control. So we do need action from the centre, but we're exploring with regions and cities what they can do at the local level. And that relates to the issue of how much do we want to change the way government operates and how much do we need to pay attention to services? It's a very interesting finding. If we look at the change in healthy life expectancy at birth between 2010 and 2019 and compare that with excess mortality during the pandemic. So the United States had a decline in healthy life expectancy in the decade before the pandemic, and the highest excess mortality during the pandemic. The UK had a slow improvement in healthy life expectancy and a big excess. Denmark, Latvia had a bigger improvement before the pandemic and a smaller excess, in fact, a negative excess. And you can see the worse the health record before the pandemic, the worse the management of the pandemic. Wow. And in England, we saw that. And I think of health as a measure of societal success. If society's improving, health's improving. If inequalities in society are increasing, inequalities in health increase. And pre-pandemic in England, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And that slowdown in life expectancy in England was nearly the slowest of all rich countries. Only the United States and Iceland were slower. And then in the pandemic, we had the highest excess mortality in the first half of 2020. So what's the link between doing so poorly pre-pandemic and so poorly during the pandemic? And I suggest the link works at 4 levels: poor governance and political culture, increasing social and economic inequalities, the reduction in spending on public services, and we were not very healthy coming into the pandemic. So do we need government or services? We need both. So services to give every child the best start in life, education and lifelong learning. These were my 6 objectives from my 2010 review. Fair employment and good work for all, having enough money to live on, healthy and sustainable places and communities, and taking a social determinants approach to prevention. But we also need to address the governance issue, poor governance and political culture, increasing social and economic inequalities, the reduction in spending on public services, and the fact that we were not very healthy. So my number 1 recommendation is to put a fair distribution of health and well-being at the heart of all government policy. Thank you.
I think you deserve a round of applause, a great presentation. Thank you very much for being so quick. You clearly showed that the relationship existing between social inequalities and health, and what we can do to reach a health justice, health of people. Thank you very much, Professor. And now, we go back to Italy, where we have a roundtable session on the Italian experience with Cristina Balest, educator, social and care services from Belluno, Giampiero Griffo, coordinator of the National Observatory on the condition of disabled people, Fabrizio Starace, director of the mental health department of Modena and councillor of the Higher Health Council, and Katie Vaccaro, head of health and healthcare for Censis Foundation. Mrs. Vaccaro is joining us. Disabilities, mental health. We will try to get a broader view from Censis. I will start with Cristina Balest, educator from Belluno. I have the fortune to work for the municipality of Belluno as educator. And I am in charge of social services in addition to working with the elderly. Our company deals with groups together, services for people aged over 65 in the city of Belluno. Moreover, we also take care of the elderly who attend daytime clinics and we deliver social services to people above age 65. During the pandemic, we had two difficulties. On one hand, we tried to protect the center that accommodates 165 non-self-sufficient elderly, whereas on the other hand, we had to keep taking care of elderly senior citizens at home. In Belluno, we have quite an old population. In Belluno, we have 35,000 dwellers, and close to 10,000 are aged above 65. So our local services deal with both residential services and local services through home-based services, home delivery of meals, and in times of COVID, many services were discontinued because it was not possible because of the lockdown to reach people. So the daytime center was closed. It was part of our residence for senior citizens, so we had no other solution because we were prevented from entering the premises. Other services were downsized, like services for people with Alzheimer's disease or dementia, or buying groceries for the elderly. At the same time, we never stopped. We contacted users on the phone and online, but home visits, for instance, were discontinued. We could not hold meetings in person. And this was one of the most severe limitation in our job, because you have to get to know the user to offer services tailored to them. That's why you have to meet with users, their families, and where they live. After over 1 year, not all users are in contact with us. Some cognitive and functional assessments that are done to access residential facilities handled by local units are still being done on the phone and not at home. As to healthcare, we during the pandemic, we discontinued specialist visits. So many senior citizens received no diagnosis, or they were not monitored, their health was not monitored. For example, people with dementia didn't have any diagnosis from specialists, and so they couldn't access services dedicated to them. Medical committees to grant validity and Law 104 again were stopped for over a year, with major repercussions for the elderly, because they couldn't They were not entitled to those benefits. Evaluations are not done in presence. They only review, papers. The number of users has declined during the pandemic. Many preferred to do things by themselves. Many elderly had their needs unmet, so they lost their functional independence and cognitive independence, or cognitive autonomy. During talks, we have come to understand that the lockdown has created serious problems, especially to those with dementia and their caregivers, their families, because those families could no longer receive home-based help. Even volunteers during the pandemic stopped every activity, both inside our residence for senior citizens, where they helped guests, they drove guests to the hospital, and particularly at home, volunteers performed a great service at home. Only now, this summer, some of these activities have started again, and now we are still facing problems caused by isolation due to the lockdown, like families that had to handle people with dementia. They were used to receive our advice, like take a walk outside the house, and they couldn't do anything during the lockdown. They couldn't contact any doctor to receive tips and advice. They could be aggressive, agitated. Those elderly were managed as they could. Sometimes they took drugs that were not appropriate for their health. In our case, we in our facility, we entered a new world made of procedures, strict protocols, where the elderly could not see their families. Families attended, our homes nearly 24 hours a day. So all of a sudden they were prevented from visiting their loved ones. Yes, of course, we did the video calls, we used the technology, we allowed people to see others through a glass panel. Think, for instance, of end-of-life patients. Relatives couldn't stay beside their loved ones. Even emotionally, this has been very difficult to tackle. I have to say that the elderly, like disabled people and other groups, those with mental problems, for instance, were in serious trouble because they couldn't access services. And slowly we are now going back to what the situation was before the pandemic. Thank you very much, Cristina Bale.
I was wondering, telemedicine. Do you think telemedicine could have been helpful? We know that some physicians have taken steps. They've tried to use IT and technology. Unfortunately, telemedicine is not widespread. In our municipality, we have houses scattered in the mountains, and they're not easy to reach. Our colleague talked about Sardinia. Well, in our region as well, it is not always easy to get in touch with the elderly people who are not familiar with technology, especially when they live on their own. Now, I would like to give the floor to Dr. Fabrizio Starace, head of the Mental Health and Pathological Addictions Unit and a counselor of the Upper Institute for Health. Good evening. We cannot hear you, or at least I cannot hear you. Do you want to try again? Good evening. We can hear you now. We have been briefly talking about mental health. During the pandemic, mental health has become a significant problem. Within the families, mental health has become a major issue, a very significant problem that has undergone an exponential growth. Let me frame the situation. Please consider the situation of mental health before the pandemic. Then, of course, we will also be talking about the present situation as documented by the surveys on the impact of the pandemic on people. As I said, please consider that in Italy, according to statistical surveys on mental health and access to services, the prevalence of psychiatric disorders, for example, anxiety, depression, the prevalence was 6-7% of the overall population. Moreover, and we're talking about more than 3 million people. Moreover, as I said, you should also consider 800,000 individuals who every year are treated by the mental health units. The mental health units provide approximately 100,000 hospitalizations. 7,000 people are hospitalized in very severe conditions due to their mental health problems. And the need for mental health is also confirmed by approximately 650,000 people going to the emergency room for psychiatric problems. So this is an overview of, this is a snapshot rather, of the situation in Italy with reference to psychiatric disorders. Inequalities are evident in this sector, and inequalities exist between the regions, but also within the same region. The mental health systems at regional level are characterized by a high degree of variability in terms of facilities, equipment, staffing, and ability to provide appropriate services. Suffice it to say that Italy invested approximately 3.5% of the overall healthcare spending before the pandemic. The year before the pandemic, the amount was drastically reduced by more than 600 million euro. and so it went down to slightly less than 3%. Let's compare the situation with the UK. The UK healthcare system is very similar to the Italian system. The UK invests approximately 12% of its healthcare spending on mental issues, and an additional increase of spending was recently approved. By 2023, 3.5 billion pounds will be added to the existing spending. So although Italy remains a model for community mental health at international level, the commitment, or rather the investments on services remain low. And in my conclusions, I will tell you why, in my opinion, this is one of the major problems to be solved. More investments are needed in those fields that are characterized by a higher degree of variability vis-à-vis the national average. The analysis of the little available data on mental health of children is not encouraging. Contrary to mental health in adults, there is no national IT system providing data on mental health among adolescents. The data I'm going to share with you were provided by some regions only. Out of 1,000 minors, approximately 200 of them in 1 year are at a higher likelihood of showing some kind of psychological or psychiatric disorder. That is 1.9 million teenagers younger than 18. And the number has increased, has doubled in recent years. A 5 to 10% increase was recorded on an annual basis. The numbers, the figures are remarkable, and they deserve our utmost attention. And even more alarming are the data on the number of minors, 200 out of 1,000, who come in contact with neuropsychiatric services. So only 60 of them will have access to services, and eventually 50% of them will follow an appropriate therapeutical rehabilitation path. So this is a snapshot of mental health in the life cycle, starting from children and up to adulthood. But this was the situation before the COVID-19 pandemic. The situation has certainly not improved, and this is due to a lack of planning on mental health strategies during the pandemic. This indication can be found in any international documents, such as the interagency association that is composed of the main international agencies dealing with mental health. For example, the WHO. And due to the higher number of psychological and psychiatric disorders caused by the pandemic, we're now witnessing a difficulty in going back to the pre-pandemic levels. And there is much more I would like to share with you. That is, I would like to share information concerning the topic of interregional inequalities. And if you download the documents that are available on the website of the Ministry for Health, and especially if you have a look at the latest document of the Conference on Mental Health, 20 years after the previous national conference, you will find the data I'm talking about. Let me share some information with you concerning acute cases and compulsory healthcare, compulsory treatments. As I said, numbers are low, but the reliability of these numbers is questionable. The regional numbers range from 4 compulsory treatments every 100,000 inhabitants in Friuli or Basilicata up to 30 compulsory treatments per 100,000 inhabitants, that is to say 7 times as high in Umbria. And one should also consider inequalities in the medium long-term healthcare services provided in nursing homes. The term nursing home is not a specific one. It refers to different healthcare modalities. In any case, services should aim at sending people back to their ordinary or normal lifestyle. Once again, regional values vary in terms of length of stay. Length of stay may vary between 4 months and more than 2,000 days of stay. These data were provided by Tuscany. Again, I will not go into the details of the inequalities. Several official documents and surveys confirm these inequalities. I would like to take advantage of the time allotted to me to focus on what needs to be done in a situation which will hopefully get better and improve resilience and community and territorial welfare systems. In relaunching territorial medicine, that is the core of the healthcare program contained in the National Recovery Plan, services for mental health, children's neuropsychiatric services, and addiction services should be improved. We need to go beyond the existing limitations, the existing funding limitations. Investments are needed on human capital. We should be investing on healthcare providers. They are the real technology behind the services. We're not talking about hyper-technological interventions. We need motivated, qualified, and trained professionals who need to establish a good interpersonal relation with their patients, thus laying the foundations for a therapeutical relationship. In relaunching the territorial medicine, we also need to reiterate some key words that we also find in the National Recovery Plan, that is proximity of the services. And I believe that the actions carried out at a regional level through the combination of the local health units, this goes against or is in contradiction with the establishment of huge healthcare units or centers providing services to millions of people. It will be very difficult for local mayors to have local healthcare plans. And also home-based interventions. Homes as the primary care center. According to the latest data for home-based mental services, they account for 7–8% of the total number of interventions. And finally, social and healthcare integration is needed. We expect this outcome to be reached in Italy thanks to the collaboration of social and healthcare policies, or the combination rather of social and healthcare policies. So this is what we need to learn from the present pandemic situation. Once again, integration, territorial approach, and home care. 3 key words. Dr. Vaccaro, in your capacity as healthcare manager of Censis, what about the most important data associated with the pandemic and the most important data for inequality? Well, I would like to focus on one element in particular to answer your question, and this takes me back to what Dr. Marmot and the previous speakers mentioned when talking about vulnerability. Well, COVID did not invent anything new. As a matter of fact, COVID exposed pre-existing weaknesses, and I would like to focus on 2 major weaknesses in particular, that is, the management of the elderly patients with specific reference to chronic diseases and disabilities. And Liliana talked about the importance of self-management at a family level and focus on women. And then there is another major issue that was also mentioned by Fabrizio, that is mental health. Everybody keeps talking about mental health, but no pragmatic actions are then taken. And I think there is a lesson to be learned from what Professor Marmot said. He said that the social determinants are interconnected, and according to his data, the social determinants do not just cover traditional social determinants such as income, education, or family resources, etc. This has much to do with the context, the environment where people live. He talked about the differences between the north and the south of the country. And this is another specificity of COVID. COVID has shown that because of the social, economic, and healthcare weaknesses, a mutual reinforcement mechanism has been triggered. People have been supporting one another, starting from an initial point that was not a favorable one. I would like to focus on some economic issues which are closely intertwined with social and health vulnerabilities. COVID has clearly exposed the criticalities of the labor market. The sectors that were hit the most were those sectors that even before the pandemic were suffering a lot. The young people, women, and foreigners were hit by the pandemic. We're talking about groups of workers that are characterized by inequalities and precarious conditions. Let me share some figures. Atypical workers in the younger groups up to the age of 35, they account for approximately 1/3. Atypical workers in groups older than 35 account for 10%, and 6% are older than 50. So people with project-based contracts, employment contracts, they're mainly young workers who used to work in the service sector, in the low-cost service sector, that is the hotel, tourist, catering sectors, and also the showbiz. People working in these fields are usually exposed to more problems. And if you think about the rate of employment for women and men, there is an 18% difference between men and women. And if you consider COVID, according to the 2021 data, out of 1.2 million jobs lost, 523,000 jobs were recovered. The remaining 673,000 jobs, well, they were taken away from young people and women. Once again, this is just to say that the gap has not been bridged. You asked me to talk about the overall national situation. Well, let me say that the jobs which have been regained, in the vast majority of the cases, they are based on temporary contracts. So I'm an entrepreneur, and of course I very much appreciate the economic recovery, but of course I have to be prudent and careful when it comes to employment contracts. So inequalities affect women also in the healthcare sector. If you think about the number of young people who are not working nor being educated, well, as Professor Marmot said, the difference is not just in the starting point, the difference is also due to gender and environment. NEET in Italy account for 23% in the age group between 15 and 29. In southern Italy, NEET account for almost 30%. If we then talk about young women from southern Italy, on average, 1 out of 4 is in this situation. They are in a standby situation. Why am I sharing these numbers? Well, because it is very difficult for these women to be enrolled in a screening program, as mentioned by Professor Ricciardi, because of course they are deprived of opportunities, and also because they live in a context that is a more challenging one in terms of service availability. And COVID has exposed these problems rather than creating them. COVID has highlighted the problems which already existed before the pandemic. To conclude, let me add a comment. I would like to talk about health vulnerability. When we talk about COVID, once again, well, maybe COVID hit all income groups and age groups, but if we think about the situations where the most severe conditions were suffered, that is to say, victims, well, we will notice that elderly patients, chronic patients suffered the most. The majority of the victims suffered from at least 3 chronic diseases. Chronic diseases, in particular, as Professor Marmot said, is a situation in which social determinants play a strategic role. If I suffer from an acute disease, I will go to hospital and I will receive a standard type of treatment, depending, of course, on the local situation, while if a disease has to be handled or managed on a daily basis, if severe conditions have to be prevented, if problems associated with my limited self-sufficiency have to be tackled on a daily basis, my family condition will play a major role. This is why, as I said, COVID was a major problem for the most vulnerable groups of people. And one very final comment that was also mentioned by Mr. Starace. The situation we are in right now goes to the detriment of those people who, in other contexts or environments, would not be vulnerable. And I mean, in some cases, people have no access to services. They cannot access to services at a local level, regardless of your level of education. The education level in southern Italy is a less effective protective variable. Having a job will not make the difference because there are people who live below the poverty line, even if they do have a job. In 1 year, this number increased from 10 to 13%. That is to say, people who, although they have a job, although they work, they still live below the poverty line. It is a very challenging moment in time. It is due to widespread inequalities at a national level, and the problem should be tackled by developing long-term projects. So temporary or quick fix solutions are no longer acceptable. Well, this emergency, as you said, has shown the weaknesses of our society, and we now know who the weakest categories are. And we're now at session number 3. Let's start talking about global health, globalization, and infectious diseases. And we have Professor Stefano Bella here with us, Global Health, Cattolica University.
Infectious disease. How do you link infectious disease and globalization? Infectious disease precede globalization phenomena. Why? Even though some of these illnesses have to do with, specific phenomena, their dissemination is linked to the typical features of globalization, like traveling, human mobility, traveling, of course, does favor the dissemination of infectious diseases, and also where we live. We all live in big cities in most cases, close to each other, packed up. So it's the population density, and then climate change, the spillover from bats to humans. We are now working on the preparedness of the population. Why? Because there is an interesting project called the Virus Project to map out all viruses inside animals, not only bats, and it's hundreds of thousands of unknown viruses. Great news, yes, they won't infect humans, not all of them, but we have to carefully consider them. And so this has to do with the spread, with the dissemination of these diseases. Another bad feature of globalization is conflict, wars, invasion, colonization. Cortés destroyed the Aztec people, not shooting at them, but just bringing a virus there, an unknown virus. So the same happened with American Indians or the Spanish flu epidemic. It resulted from the war, movements of troops during the First World War. It originated in the States, in the Americas, and also syphilis. Small or large, areas of syphilis in Europe. It was the French army landing in Naples to fight against the Spanish. It is also called French malaise or Neapolitan malaise because people blame each other. So infectious diseases come from traveling. Think of Yemen and the war there. So how an epidemic begins is pretty clear, but do they end? Yes, they do. In most cases, great question though. If you have a vaccine, yes, an epidemic ends. It took 8 centuries to eradicate smallpox, and we succeeded only when a vaccine was discovered. We're nearly there with polio. Africa has been declared polio-free. But with globalization, we have the so-called poverty-related disease. Now we have a vaccine against malaria, but this is not new. This is an old vaccine that now has been tested. It doesn't cover fully, but it covers children and saves many lives, but it doesn't eradicate malaria. With tuberculosis, the vaccine dates back to 1897 or something. 2 guys did invent it. We have no vaccine against AIDS, but we have drugs. When there is no vaccine, but COVID, for instance, mutates, yes, we don't have an Icelandic mutation of COVID-19. Why? Because it was not so popular there. Mutations originate from countries where the virus travels free. The Indian mutation, they had a catastrophe there. It's a bit better now. India now produces vaccines locally. The Serum Institute is the largest world producer of vaccines. It was making vaccines for COVAX and other countries, and now Indians are keeping those vaccines for themselves, and so things are improving. The so-called Indian, the Delta mutation. Now we have the Mu mutation that comes from Colombia. It seems that it can escape vaccines. So we can't immunize the entire world. Mutations are bound to reach us, to come. Good news then. So unless you immunize the world, mutations will take over. Vaccines are working against the current mutations. mRNA vaccines can be modified. Another 100 vaccines will be introduced, but they will be introduced in wealthy countries only. And we will repent about this. We will heavily regret this choice. So pandemics end with vaccines, yes, or they end, and this is a mistake that some governments did, when a large proportion of people gets sick. The Spanish flu H1N1 virus went away with no vaccine, simply because 100 people died, but only 2 billion people lived on Earth. It's 7 billion people now living on Earth. So it killed 100 million people and infected 1 billion people. So the virus couldn't find any more space. The only barrier that we have now is the vaccine. In some countries, some policy makers talked about the so-called natural herd immunity, let the virus circulate, and with catastrophic results. The UK government has been harshly criticized for what they did before starting the vaccination campaign. So give us one good news to end your talk. The good news is that eventually we have learned something, and it's a lesson about being humble. Our world believed it was invincible. Not at all. We were slapped in the face. Now we get to be prepared. What should we do now? We need to be prepared against a possible new pandemic. One possible pandemic could be an influenza pandemic, and we don't have only bats. So you have to put together a surveillance network with fast alerts. And then there is another project I am following, the 100 Days project. It's a UK, but it should be a universal project where people are prepared to make vaccines in 100 days against any virus. Problem is that vaccines, you can make them in 100 days, but then you have to manufacture and distribute them. And this is our flaw. This is this is what we should be ashamed of. Thank you very much, Professor. Let's go on with migration and global health with Giovanni Bellio, Director for Research and International Relations at Agenas.
Eccoci qui. Thank you and good evening. Here we are. We'll be talking about a relevant topic, that is our relationship with the environment. What about our diseased relationship with the environment and the pandemic? And also, what about its consequences, such as social inequality? Let me share a few comments in agreement with what the previous speakers said. The pandemic was characterized with social distancing, face masks, no social gatherings, hence the division, the separation between us and the surrounding world. Such separation has instilled a socio-environmental thought in our minds. Health is not an integral part of the human body. Health is associated with the quality of the relationships between human beings and nature. And of course, this is also associated with the kind of community that we have been able to develop. And as the COVID has shown, the relationship between human beings and the environment has changed. One of the previous speakers mentioned that according to the evidence, environmental deterioration, air pollution have significantly contributed to COVID-related mortality rate, chronic diseases, and the weaknesses associated with one's social and economic status can certainly increase or worsen the death rate associated with COVID-19. So what's the take-home message here? We need to rebuild our relationship with the environment. And if you think of the global guidelines that were recently updated by the WHO, well, these guidelines now reduced the environmental pollution thresholds or values. And also think about inequalities. Reference was made to proximity. I have been working with marginal people, and I've learned some important messages or conclusions affecting proximity. Healthcare systems. Of course, data are not always sufficient. You also have to consider important models. Models have been developed to the benefit of disadvantaged categories. And let me tell you about some tests and experiments. Public proximity health is focused on the relations between private social organizations, communities, professional and public institutions. This alliance must be built and strengthened in order to create a healthcare system that can meet the needs of the people. For example, taking advantage of the outreach models and other models that can reach different categories in different environments. And also, you also need to rethink your own system to guarantee better access to the services. And working with the outreach groups, we have learned that proximity public health cannot be a healthcare system that is just based on places. This type of healthcare system should be based on a dynamic approach. You need services that go beyond the boundaries and the walls to get to the people. Are you talking about home-based services? Not just home-based services, but also active healthcare services, that is knowledge, but also active provision of preventive measures. Several initiatives have been undertaken to the benefit of the Roma, Sinti, or migrant communities, and also in jails, right? Services were also provided to inmates, another challenging topic. So this is what I call the dynamic approach. Healthcare providers going out of their working sites or healthcare centers. This is the overall idea. Get out, reach people, and understand their needs. And then there is a second movement, that is to say, the inward movement, that is to say, the services that went beyond the walls have to rethink themselves and provide a different type of service. This is the so-called system mediation. So in this loop, we also need to take communities into account. Communities have to be empowered and contribute to co-construction of healthcare services. We need the kind of solidarity we were talking about a moment ago. Solidarity weakened because of COVID, but it had already weakened before the COVID-19 pandemic. So as somebody said, COVID made these problems even more visible. Let's keep talking about the environment, but from a different point of view. We will now be talking about climate change. What about our perspectives for health? Alessandro Messeri from the Bioeconomic Institute and the Climate and Sustainability Foundation.
Buonasera a tutti.
Good evening.
Buonasera.
Good evening. I'm not sure I can hear you. We cannot see you. Here we are. Good evening. Welcome. A question for you? Why? I know this is a rhetoric question, but why has climate change an impact on human health? And what about our future? Climate change is becoming an integral part of our life. We cannot hear you. We have a technical problem. Let's try again. Some technical problems. Can you please keep on talking? Let's see if you... Can you please disconnect your earset? Please disconnect your earset.
Adesso mi sentite?
Can you hear me now? Yes, very well.
Benissimo,
If you can hear us, we're fine.
perfetto. Allora, innanzitutto vi ringrazio,
First of all, I would like to thank you.
vi ringrazio per l'invito e vi ringrazio
Thank
anche
you for your kind invitation.
Scusate perché ho il
Again,
ritorno
some technical
dell'inglese,
problems.
ho il ritorno della traduzione e non sento e non vi sento in studio.
Adesso parliamo solo
Unfortunately, I
italiano.
cannot hear you.
Quindi, ecco, va bene?
Perfetto, adesso sentivo solamente in inglese.
I could only hear the English version.
Allora, vi ringrazio appunto per
Thank you very
l'invito e
much
soprattutto ringrazio
once
Asvis
again for your invitation, and I would
per
like
aver
to thank
organizzato un evento
Asvis
secondo me è
for
molto importante perché
organizing
affronta
such
due
an
tematiche
important event.
molto
Two
centrali
major
e molto
issues have been
interconnesse tra
discussed
loro,
today,
i
and
globali
these issues are
e
closely
la nostra salute.
intertwined.
Incontri di questo tipo credo che siano molto utili
Meetings
anche perché danno
like
degli
this
spunti di
one are also
riflessione molto
helpful. They give
importanti,
us food
sfruttabili
for
poi
thought.
anche per quanto
And of
riguarda
course,
delle decisioni politiche.
initiatives like this one play a major role when it comes to political decision making. As already mentioned, in my presentation, I will be focusing on climate change and the impact of climate change on our health. And unfortunately, I'm not going to share any good news with you. It is a fact, it is well known that the climate is influenced by CO2 emissions. Scientific evidence shows the relation between CO2 man-caused emissions and the increase in the planet temperature. And according to the latest 2021 report on climate change, we now know that there is an alarming situation. We now need to reverse this trend, and in any case, we still have to coexist with the consequences of climate change. We now need to develop strategies to adjust ourselves to climate change.
CO2 emissions are related to energy generation, electricity generation, and the same goes for agriculture, husbandry, industrial manufacturing, transport, and also heating, residential heating systems. COVID, due to lockdowns across the world, has curbed CO2 emissions. But this won't affect climate change in any way because the 20 hottest years in history have occurred, have begun in 2000. 2021 is not over, but seems to be as hot as 2020. If those with white hair can easily compare their past years with what is happening now, the younger generations like teenagers probably don't realize how unnatural this climate is. So emissions do affect climate, weather, and climate and weather affect our health. How? On different levels, directly as well as indirectly. It's not easy to anticipate future impacts. WHO and other organizations, including climatology and meteorology research centers, have emphasized the impact of climate change on human health in the last month and years, also the public opinion has become aware of this. Scientifically speaking, we have a large number of papers discussing the effects of climate change on health. So this is a recent review highlighting how most international scientific papers on this topic focus on infectious disease, mortality, the effect of climate change on the development of the increase of respiratory and cardio-circulatory illnesses, and the impact that climate change has on healthcare systems and also on mental health. How? Well, it acts at different levels. Number one, oceans get more acid due to greenhouse gas emissions. Aquaculture and fisheries suffer from these problems, and we have also, for instance, drought, high temperatures, other extreme phenomena having an effect on crops, causing a loss in production. Climate change also has a direct impact, like heat waves, causing an increase in cardiovascular conditions. Emissions of pollutants, ozone and thin powder affect our respiratory system. The temperature increase causes move of some species from some areas to others, causing problems in terms of pollen distribution, increase of allergies, and also an increase of vector transmitted disease. These and other aspects have repercussions on societies. So it can create problems like increased poverty, mass migrations, migration flows now and in the future, conflicts, and so forth. One of the most macroscopic and visible impact is natural catastrophe. According to MDAT, it's an unforeseen and sudden event causes damage and destruction, and natural catastrophe, natural disasters have significantly increased in the last 5 decades, and in the last 2 decades they increased even more. In particular, storms, extreme temperatures, flood, drought, landslides, and fires. Many papers, one is very recent, show that global warming due to CO2 emissions is causing a decrease in the number of hurricanes and storms globally, but they are stronger than ever, and they are happening in new areas where they never happened before. A recent paper from 2014 shows that the healthcare effects of flood, tornadoes, and storms are very many on health. They can be direct effects like a cardiac arrest, flooding, fulguration, car accidents, or they can happen in the medium run, chemical intoxication, polluted water, mental disorders, post-traumatic stress disorders due to floods. And the number of landslides and floods has been gradually increasing in Italy too, especially in the north of Italy, in northern Italy. Another extreme phenomenon is heat waves. They have a huge impact on mortality, especially in developed countries, where 76% of deaths caused by natural disasters is due to heat waves. In Europe, 80% of deaths due to heat waves, over 80% of global deaths due to heat waves happen in Europe. So, these two papers show that in Italy and in Southern Europe, in the last decades, we have seen more frequent, longer, and late heat waves, even in the early fall season. While the global temperature is expected to increase further, we should reduce its impact, because the deaths due to heat are on the rise and will be rising. Most of the global population live in highly urbanized areas where buildings contribute to increase heat. Less green and more people living in the cities, so CO2 emissions are highly concentrated, causing a temperature increase between 3 and 10 degrees in summer, causing a higher risk for human health. Some groups are more vulnerable: the elderly, children, those with chronic conditions, people living in developing countries, athletes, and workers. This is often underestimated. In recent months, we had many accidents in the workplace. Workers are at risk. A recent paper published by INAIL shows a higher risk of injuries in the workplace due to extreme temperatures, heat in particular. These are workers who stay in the sun, are in contact with equipment generating heat, do not wear the proper protection devices, so that's why projects, international and national alike, are being funded to develop adaptation and prevention strategies for workers. This is a Horizon project that aims at realizing an alert warning system for workers. It's being realized. It's a platform to alert Europe. At the national level, we have another project financed by INAIL to develop a similar system, more sophisticated, that also considers other aspects, the weight and height of each worker. So this means that all goals are closely related. Fight against climate change, health, right to work, they are all intertwined. Thank you. Now, we have one final speaker, Giampiero Grifo, from the National Observatory on the Conditions of Disabled People. We can hear you. We can see you now. We discussed about proximity, home care. What else can we say? I'm sorry, we cannot hear you. My observatory oversees the enforcement of the Convention Agreement for the Rights of Disabled People. During the pandemic, Commissioner Elena Velli from the European Commission has stated that disabled people have been disproportionately affected. And emergency systems actually virtually ignored us. One association, the Italian Society for Anesthesia and Intensive Care, at the beginning of the pandemic, when there was no proper facility, not to help people, severely disabled people. The lockdown did block every type of intervention. Just the families were available. So in May last year, 41% of people living in residential facilities die, let alone FAD, preventing over 60% of disabled students to attend classes. So Italian welfare was not up to the task. The welfare system has to change. The present welfare was established during the First World War. We now want an inclusive welfare. Wherever we are, we want to enjoy the same opportunities as other people, as other citizens, as the Convention states. So we want to pass a law amending the welfare system. Disability is the interaction between functional limitations and the way society, environment, and the prevailing culture ensure full participation of people. Every time you encounter a barrier, and there are many, you violate human rights. So disability isn't subjective. It's an interaction. And this should be acknowledged by the state. Disability is a social output. And that's why we want to change systems, design systems. They should be centered around individuals. To express their voice, desire, and aspirations. In a way, this shows that the current system makes us vulnerable. We are not vulnerable per se, it's the way society prevents us from participating. We are pushed into a corner with no resources. We are citizens exactly like everyone else. This is a cross-cutting issue. The recovery plan hopefully will fulfill the rights, the needs of disabled people. We submitted a draft directive covering all 6 missions. This is why it's a cross-cutting theme. So accessibility should be guaranteed. In Italy, we have laws about accessibility, technology, system transport, but very often those rules are ignored. And also inequalities, youth and women. Well, we have disabled youth and disabled women. Right now, according to the latest census, 36,000 students are disabled and they go to university. Does the recovery plan help these people too, giving them an inclusive future? And then SDGs, the UN introduced disabled people in all actions, especially education, employment, inequalities, and accessibility in the cities, and also data collection. We have a major bonus, a weakness in Italy. According to WHO, 15% of the population suffer from some disability. According to the European Union, 16%. In Italy, according to Istat, only 5.2%. All people are bound to suffer from some disability during their life. That's why we want to give them all the possibility to be included, to participate. The protection welfare model considers us as an object. We are subjects of change, agents of change. We account for a share of Italians. Thanks to the association, the different law decrees have introduced measures to protect or defend us. During the pandemic, disabled people were overlooked. We generally say, nothing on us, nothing without us. Not only a slogan, a methodology, a system of rights. This slogan should underlie change. The recovery plan includes several interventions. They should be, first of all, homogeneous across the country. So the law should set standards for projects to be based on participation, disability, and support to allow people to be included. The convention agreement is a standard. It should be observed by the regions. It doesn't happen today, not consistently, and this is what we have learned from the pandemic. So we can't miss this opportunity. Thank you. Thank you all. We have one final roundtable about globalization and in-field experience with Sara Albiani, Policy Advisor for Oxfam, Rossella Micio, and Aldo Morrone. First of all, I suggest to applause Gino Strada for all he did for a world of peace. Sara Albiani, global health, what does it mean? What is it? Global health means considering health as a common asset. It's easier to say what global health is not. It's not seeing a situation where during the pandemic only 2% of low-income countries receive a vaccine, whereas 66% of people are immunized in high-income countries. Global health is not inequalities in access to healthcare systems or life expectancy. Global health is considering the health of everyone as an asset and a universal right. Inequalities affect also health, especially after the pandemic. We have seen this. Oxfam experience, what does it show? We have seen dramatic situations in the last 18 months due to a lack of access, particularly in Africa, to healthcare against COVID or individual protection devices, diagnostics, etc. Those countries, people seem to be unable to fight against the pandemic and protect the population. There is no global vision. There is no awareness of the fact that this virus is just doing its job. It replicates, it may develop mutations, making our efforts useless. We see a national approach, not a global approach. So where we operate, we see that access to tools and instruments containing contagion is quite bad. Right now, the World Trade Organization is debating a proposal to act against the deep roots of such inequalities in terms of vaccination. In low-income countries, we still see monopoly systems based on patents held by pharma companies. Due to patents, only pharmaceutical companies that have developed the vaccines can manufacture them. And of course, they set high prices, preventing low-income countries to buy them, to buy COVID vaccines. So we don't have enough doses, and those that we have are quite expensive. The pharmaceutical industry did make a huge effort to develop vaccines, and this effort must be repaid However, don't forget that R&D activities were funded by public authorities. 83 billion euros were granted by governments to fund R&D activities for vaccines. So we want to temporarily suspend patents. It's not the only solution, but it is essential for poor countries. Firms and companies that can manufacture companies are located in many low-income countries like Bangladesh or Indonesia. They should be allowed to manufacture vaccines. Sharing technology should be made available by drug companies, and we also call for investing in the manufacturing capacity of those countries. In Italy too, it wasn't easy for us to receive masks or respirators because we didn't manufacture them, so we had to import those items. And the same goes for vaccines. Some countries manufacture vaccines. They are located in low-income countries too. Their production capacity should be further stimulated in view of future pandemics. We are still fighting against COVID, but don't forget that the virus keeps circulating. And so we may have to live with COVID for a long time. We should adopt a medium-long-term approach. We need a global manufacturing capacity. Our proposal is not new. WTO rules allow for the suspension of rules protecting intellectual property in exceptional circumstances like this. This is why we need a political leadership that makes major decisions, particularly in countries like Germany, UK, the European Union as a whole, and alas, Italy too, because Italy on this front hasn't taken a strong position. Health is a global public asset. We should go beyond words and act. Vaccines should be accessible to all. Thanks, many thanks. Rossella Miccio. COVID-19 has been an emergency during an emergency, right? Thank you for remembering Gino Strada, a major figure not only for emergency, but for Italy and the rest of the world. Yes, COVID was an emergency inside an emergency. When we received the news about the virus spreading in China, we decided to adopt security measures in the hospitals where we work, because those countries have strong ties with China and their healthcare systems are quite fragile and weak. We couldn't imagine that the real impact would happen here. And we were in trouble. In January, February last year, we sent materials that we thought could help during this emergency, although this was an unknown virus. However, we couldn't allow in those countries that facilities delivering life-saving services, maternity wards, the cardiac surgery center in Sudan, we didn't want them to stop working because many people would have died indirectly. So this is what we did. We also strengthened security protocols to prevent contagion. We delivered training to the staff, some 3,000 colleagues. It was the right decision because unlike what happened here when the pandemic arrived to Italy, even though our healthcare systems is well advanced, it was paralyzed for months. And this is still showing its consequences, particularly for the weakest populations, chronically ill patients, cancer patients, groups that hardly receive care, migrants, homeless people. It was terrible for them. But here we could invest resources to buy what we needed to control the pandemic, protection devices, respirators, diagnostic tests. In the rest of the world, this didn't happen. In February this year, I was in Afghanistan, and during the meeting with the health minister, he said, for the first time, we cannot access or buy what we need, although we have the money. We have money, but nobody sells materials and equipment, masks, tests, respirators. This was a tangible sign of how big inequalities are. It's a structural element. Sarah said that global health means considering the health of each and everyone as our own health. Unfortunately, we've seen that this isn't true. In reality, this has not happened. Still today, access to vaccines in many countries is limited to donations or COVAX. But this is about us, not just them, because the virus keeps traveling. It's gonna mutate. Nobody can say whether a more aggressive form of the virus will come back. And this is something that is not clear yet to many. People keep talking, but in practice, the notion of equality, dignity, and rights, as stated by the Universal Declaration of Human Rights, is still on paper. It's denied and rejected and discarded. By the way, access to vaccines in many countries has been going on and off for months. They only received one vaccine, the vaccine made by the Serum Institute in India, licensed by AstraZeneca, without realizing the distorted messages we were sending across. Because here, say in Italy, in Europe, we decided not to give AstraZeneca to people younger than 65. In those countries where the mean age of the population is 25 or 30, that was the only vaccine available. So this is very unfair. It's like saying we don't respect you. You have no dignity. In Uganda, the Minister of Health asked international organizations in the country to get immunized, to be an example, because people didn't trust the vaccine available. In that they said, well, in Europe, people are not using this. So this is hard to overcome. The next G20, chaired by Italy, hopefully will show a bold move to overcome such inequalities, realizing that we can win only if everybody wins. It takes a global view, a global vision in the face of emergencies. Viruses are invisible and travel across any physical barrier, including social and economic barriers. The impact of the pandemic on the most vulnerable groups has been pretty serious. Everywhere in the world. We are working on different fronts with Oxfam and many others. We do international campaigns for the access to vaccines. There is a European campaign to raise 1 million signatures by Europeans, asking the European Union to pass legislation against patents being an essential asset to fight against COVID. So it is our responsibility to act all together. Aldo Morone. Global health. Are you optimistic? Please say yes. I prepared some slides, but indeed I'd rather talk off the cuff. In the so-called developing countries, we should rather call them countries heading for underdevelopment. Anyway, what strikes me is that COVID has shown sharp inequalities. COVID has demonstrated unfairness. It was already there in COVID too, in Italy too. COVID killed the poorest and those in residential facilities. Tropical neglected diseases, but we also have neglected people. Those diseases can be easily cured if you only want to, but since they affect poor people in poor countries, I worked for a long time on malaria. This vaccine against malaria is extraordinary, but has nothing to do with mRNA COVID vaccine. Here, a financial, technological, scientific, huge investment has been made. Why? Because the virus was hitting the north. Malaria hit the south. Malaria has never been eradicated, Professor Vella said, but malaria kills more than COVID. Malaria is the second most powerful disease after tuberculosis. And even about SDGs, eradication of poverty, not yet. Poverty or impoverishment? First, water. In some countries, there is no drinking water. The only water people can drink is not drinkable, meaning that millions of children suffer from diarrhea and die of viral gastroenteritis with very little interest by the West. Drinking water is a very powerful solution against many diseases. Rainwater should not be collected during the tropical season and use it for commercial purposes. In Italy, what impresses me is that we stopped healthcare services, we discontinued services, but this is not new. This happened even before COVID. People should be treated early, and there is only one way to do it, to pay out of your pocket. This is a profound injustice. The best and most democratic service is the emergency aid. Whoever you are, they treat you. But then the poorest stay in the emergency ward, and when they leave it, there is no integration, no inclusion for them. So the virus has shown a dramatic situation in the south, in southern Europe, particularly for homeless people, migrants, inmates, pensioners receiving a very small pension, those who have no money. When the campaign I Stay at Home was launched, yes, it was nice in February last year, but tiny detail, a huge number of people couldn't say I stay at home. If I had a home, so we decided to offer homeless people and migrants to receive a diagnostic test. When we were locked down, we did serological tests. We involved several associations taking care of frail subjects, including social workers. Well, 7–8% of those tests turned out to be positive. Those people were sick, never realized to be sick, and received no treatment. Unacceptable. We had to challenge the authorities. If you find someone positive, how do you isolate them? The so-called COVID hotels, indeed, it turned out, had no interest in receiving those people, homeless people, or people with no documents. We submitted a research project to Spallanzani Institute. We found a facility, but even the authorities didn't like us to do tests in the streets. We also sequenced positive subjects. We found the Bangladesh mutation, for instance. Then we vaccinated those people. When the vaccination campaign began 1 year ago, cancer patients and other groups were forgotten. Homeless people were forgotten, and also foreigners with no papers. Why? Because they couldn't be entered into the regional files, archives. We found a solution for this. And so those people were immunized, but it wasn't enough. We asked these people whether they accepted, whether they were available to accept receiving a test, a swab, and an antibody titer response prior to vaccination. Out of 1,000 people, half of them already had antibodies, meaning that those people had been infected, had gotten sick, nobody had treated them, and nobody gave them the opportunity to be followed by the healthcare system. So when Marmot talks about injustice and inequalities, well, we shouldn't forget that Italian healthcare system is one of the best in the world. But, there is a serious but, this system leaves the most marginalized, frail people behind. People are left in a marginalized condition. They can't use the latest technologies available. Scientific research deserves being revised. Do I do scientific research for profit-making reasons or because I really want to cover all, no one excluded? I remain positive and optimistic. I've seen people, centers, extraordinary people. I went to Lebanon, I went to Ethiopia. I've seen outstanding people there. In Tigray, there is now a civil war that exploded during the pandemic, and the UN is not pushing as they should to stop the war, because again, we have different levels of war in certain areas of the world. People don't care about conflicts. Everybody talks about G20. I suggest we should have a G20 of the last 20, not the first. Doctors are no longer authoritative. People suspect that we do things for money. People don't believe that we listen to patients. People think we are an accounting entry for hospital companies, not allowing, not giving space to anything but money and profit. It's a shame. We want to be authoritative and transparent and honest so that people trust us. If whenever we recommend a vaccine, a drug, it's not because we have an interest, but simply vaccines are a weapon against the virus. We don't give the vaccine only to some countries. This is a pandemic, meaning that the entire planet should be immunized. We don't want an escape virus escaping the vaccine. However, I remain optimistic. Thank you for your passion and for your final word of optimism. Thank you all. Raffaella Bucciardini, Carla Collicelli and Carla D'Angelo, Asvis Working Group on SDG 3. We have some graphs to show figures, numbers, measure and matter. This is the number of beds for acutely ill patients every 1,000 inhabitants. This number dropped by 13.5% between 13 and 19. This number explains, shows that resources and funds have been decreased, as we've seen during the pandemic. In the middle, you can see behaviors at risk in alcohol consumption and smoking. While a positive decrease was observed in those years, in 2020, this trend was reversed, and this is considered as a side effect of the pandemic due to lockdowns and restrictions. On the right, life expectancy at birth, a fundamental indicator. In 1 year, we have lost 1 year of life. Our life expectancy drops from 83.2 down to 82.3. The diagram below shows the favorable trend of SDG between 15 and 19, followed by a decline with the pandemic. This confirms we need a global approach to health. Longer-term care and treatment should be reorganized, particularly for non-self-sufficient, non-independent people and the elderly, with a view to social aspects like infrastructure, social services, and local services. And this should be consistent across the country. We believe it is important to promote the collective dimension of health. Prevention is a key requirement. And finally, healthcare systems requiring flexibility. They need flexibility. 4 minutes left. May I thank all the speakers, Asvis and Laura. Thank you. I hope to follow up this event and the whole festival that will end tomorrow. I see a huge gap between what we know and what is done. Global health is not new. Inequality has been there and debated for years. all countries are more or less aware of these problems, but we have to act. I don't see actions. So we have come to a historical time that is also connected to a cultural time. I'm not calling it by name. So I would coin the term globocentrism, driven by two notions: putting us and not the ego at the center. Individual initiatives have destroyed Italy. We had a session about community. Us should be at the center, and then science should drive us. Whatever we do should be science-driven. These two pillars should be implemented. How? Through a follow-up. Asvis has a soul that embraces the different skills, experiences, and areas. Asvis could be the best counterpart, the best stakeholder to express our needs to policymakers. This event, I hope, ends with a declaration, a statement to be submitted to the government to monitor so that something does happen. Time is up. What indicators did we use? Let me only say that the Goal 3 working group dates back to a long time. We felt lonely because the other experts didn't consider us. With the pandemic, we feel stronger and more empathetic with others. There is a great deal of interest in this topic. We want to continue, we hope, in a concrete alliance with you, with the representatives of our members who are part of the Goal 3 working group. Thank you all. Thank you all. Act now, and now is late. The festival continues tomorrow at 10. The closing event will be broadcast on Asvis channels. Thank you.